Oh. Mm. Hello, Vietnam. Can you hear me, Vietnam? Okay, you're in. Oh, Good morning, Jose. Hello, Wan Lee.
Hi, yeah, John, yeah,
How you doing?
good. It's okay.
Usually you're on the road, you're traveling.
No. So today I'm at home. Yeah. Okay,
Oh,
yeah,
okay.
it's okay. Yeah.
Very
So,
good.
today we wish have the Dr. Chen as the first speaker. You know that?
Okay, so you want Jose is going first,
Yeah,
right?
because Dr. Chen he will have some business
Okay.
after the talk, so he want to
Yeah.
be the
Good morning, Jose.
first
Good
speaker.
morning, good morning.
Yeah, you're gonna be first, okay?
No, I think Dr.
Okay,
Chen
Jose.
wants
Oh, no,
to say-
who'd you want first, Wan Lee? I'm sorry.
No. Dr. Chen Zan from Beijing Shanwu Hospital.
Oh, so he's gonna be first?
Yeah. He
Okay.
said he cannot be online after 9 p.m. So yeah,
Okay,
and that's about. I think he will talk about 30 minutes. So
okay,
Yeah.
okay. He's going first, right?
right, I think
Yeah,
he's
okay, so I'll
already.
introduce you first, okay?
Yes, okay. Yeah, Bing
Let-
is
Let me,
Chen
Hello.
is still
Hi,
good morning, Ben.
hi,
How you
John.
doing?
Hi,
You know
Yuan.
Jose, right? Jose
Yeah,
Valerio?
yeah.
I'll say, yeah.
Friend?
Let me see. Is
Yeah,
is
I'm gonna turn it over to Ben and he can organize it. Okay, Ben, I'll turn it over to you and you just organize it how you want, okay?
Yeah.
Okay. Or you introduce Wan Lee, whatever you want to do.
Okay, let's Professor Chen Zan, he have a boarding train to catch, so let
Yeah.
him be the first.
Okay.
But
Okay.
seems
Here we go. 10, 9,
Mhm.
9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett from sunny Miami Beach, across town from Jose. Today we have a regular bi-monthly China Neurosurgical Journal webcast. And we have leading the procedure, a notable neurosurgeon from Shanghai, a great guy. He's a leader in the field of teaching. So Ben Zhu, welcome.
Thank you, John. So today we will have two distinguished speakers. The first one is Chen Zan from Beijing Shanwu Hospital. Professor Yuan Li, please introduce Professor Chen Zan.
thank you, Dr. Xu. Today we have two speakers for our Chinese Neurosurgical Journal webinar, and I think problem is Dr. Chen, he's not online yet. Dr. Chen Zan, are you there? I don't see his name from the list, so maybe we still can have Dr. Hasha as first speaker.
Okay, so let's Jose be the first speaker.
What would you like to do, Ben?
Yeah, I guess
Yeah.
Dr. Chen got some problem with his internet connection, so maybe we still invite Dr. Hassan. So Dr. Xu, can you introduce Dr.
Valerio?
We can give it 5
Oh.
minutes. I'm okay with that. We can give it time.
Oh, that's Jose Valerio, right? Dr.
Yes,
Jose Valerio from Miami, right?
correct.
So yeah, maybe Dr. Xu, can you introduce Professor Valerio?
Now, Dr.
Okay.
Chen is the doctor presenting?
Dr. Chen, he's not here yet. I will.
He's here now. He's here now. He's here now.
Oh, really?
I'm sorry, Jose. We're so
Okay,
disorganized.
okay.
Oh, yeah. I
He's
saw
here
his.
now. Okay.
So yeah, Dr. Chen Zan. He's from. Okay, I saw his name. Maybe we wait for 1 minute.
We're not going to get the prize for the best organized webinar.
Sorry. Yeah. There's
Sorry.
some.
Trying to get him in now. He's in the waiting room. I guess he's having no trouble getting in. Come on, Dr. Chen. Okay, it doesn't seem to be coming in okay. I don't know what's going on. I've invited him in. Doesn't seem to be coming in. Jose, this has not happened before. There's always a first, I guess.
Okay, don't worry.
Are you communicating with Dr. Chen at all, Wan Lee, or?
I'm asking him, but he didn't. Let me try to call
Yeah.
him directly.
We may have to skip him because he's not getting in at all.
Yeah.
So
Yeah.
keeping Jose waiting and everyone else waiting.
I think we can just start with.
Don't worry for me, John. If Dr. Shen need to give the presentation before he flies, I'm okay with that.
Let me try to.
Okay, well, I'll leave it up to Ben what he wants to do, whatever.
Yeah, I think we can just start with Professor
Okay.
Valerio.
Okay.
Yeah.
Okay, Ben, could you please introduce Jose? Oh, maybe Ben. Ben, are you there?
Yeah.
Yeah, could you introduce Jose, please?
Okay. Professor Jose is from Miami. He is a very famous neurosurgery oncology specialist and spine surgery. So, Professor Jose, today his topic is the advancement in the management of high-grade gliomas. Please, Professor Valeria.
Thank you very much for the opportunity to give the presentation. Let me try to share screen here. Okay. You guys see this?
Yes, perfect.
Yes.
Okay. So I'm gonna talk today about glioblastoma treatment state of the art, and I'm gonna disclose consultant for Brain Labs, Stryker Spinal Navigation, Remy Robot, Aero Intraoperative CT, Sofisa, SI Bone, and Camber Spine. So let's start from the beginning. What is this specialty? Why neurosurgical oncology? Why tumor board and why us? I think it's important to understand first what neurosurgical oncology means. So the neurosurgical oncology is the treatment of patients with both benign and malignant tumors of the brain, skull, skull base, spine, spinal cord, and peripheral nerve. The clinical years provide fellows with extensive experience of surgery and radiosurgery for these lesions, brain tumors, pituitary tumors, and skull-based tumors, so spine tumors and peripheral tumors. And some of them do extra years to do pediatric brain tumors. But the most important part of it, neurosurgical oncology, as different to other neurosurgeons, is they need to optimize the techniques and technology in neurosurgery, has the ability to do local delivery, direct injections, wafers, conventional enhanced delivery, or try to use novel therapies like obtain tissue, genetic analysis, create vaccines, and tissue levels. So with this new ability, we are in the era where we have the capacity to use a functional MRI, DTI, spectroscopy, image guidance, frameless biopsies, the use of intraoperative MRI or intraoperative CT, the ability to operate in eloquent areas, do mapping, and do awake craniotomies. We were able to start to do resection in motor cortex. We have been seeing that the majority of the gliomas displace the corticospinal tract. We are doing to do it awake. We are doing to work in language area. We know that is the ability to plasticity. And after surgical resection in these areas, we have a 3-month rule that is the maximal benefit to do physical therapy and language therapy. And when we do a neuromonitor, we have the 1 centimeter rule where we're getting the reduction in the stimulation of the motor area to stop. Actually, some schools recommend even 5 millimeters. So we also know that seizure is also an indication to do surgery in patients who have gliomas, even they are considered low-grade gliomas, because these seizures can be displaced or can be moved to another area in the brain if you don't do resection in less than a year. So simple partial seizures, duration of the seizures, and temporal lobe location are one of the indications. And we have, with the advance of navigation, to do resection and pre-analysis of what we're gonna do. So here we have an example of a low-grade glioma that is close to the motor cortex, and we can do an analysis pre-operative to see how the motor cortex or the corticospinal tract is displaced. We are able to fuse the functional MRI, the corticospinal tract, and we can able to analyze that it's a subpial plane that you can resect to do a gross total resection of a tumor and preserve the corticospinal tract. Now, with this kind of craniotomies, we can do stereotactic craniotomies, do surgery in supplemental motor area and motor cortex, and identify what is known as the phase reversal. That is the area. That is the area that shows exactly where the motor cortex is and the central sulcal is, and you can compare this to your navigation system, and you can stimulate this area in patients that are awake or patients who are asleep without paralytics. So this stimulation gives you a combined information between the functional MRI, the functional treatment to the patient in that moment, and you can identify the area. So you can use the Oyeman to identify where is the motor cortex and what is the sensitive area, and identify the central sulcus. And this is what is known as subcortical navigation, subcortical stimulation, where you can do resection and you can be stimulated before you go to the corticospinal tract. And 5 to 8 millimeters, that is my recommendation. You see that you are with monopolar with respect to the corticospinal tract, 1 to 1 millimeter. You can identify the distance and you can stop your resection. And this is the patient that we discussed 6 months later after surgery. So can we really achieve a complete resection of a glioblastoma? The answer is no, yeah, but we need to understand that we can do a maximal resection, and we need to identify that there are like 10 different kind of high-grade glioma that we need to stratify. Because every glioblastoma has different treatment and different diagnosis. So you have anaplastic astrocytoma, anaplastic oligodendroglioma, anaplastic oligoastrocytoma, primary glioblastoma, secondary glioblastoma, giant cell glioblastoma, small cell glioblastoma, Rosette cell glioblastoma, glioblastoma with oligodendroglioma features, and gliosarcomas. So stratification is important. Even the molecular diagnosis is important to define what kind of tumor it is. So if you have a primary glioblastoma that is EGFR amplified, you know that the maximal resection of the tumor make a difference. And this is the tumor that you also need to give Celadex, that is a EGFR vaccine, that you can treat it and improve the prognosis of the patient. If you have a patient with a giant cell glioblastoma, you know that gross total resection of the lesion have a significant good prognosis of tumor, and you need to be completely aggressive. IDH1 P90Q has been key factors in the management of this patient, and we can see the presence of a wild IDH in patient with low-grade glioma that need to be considered as a metabolic GBM and need to have a gross total resection. That's why the reason of a low-grade glioma has to be increased the need to do surgical resection. And here is an example of what I just explained with a new World Health or a classification about the use of IDH wild type or not. So you have here patient with IDH wild type in low-grade gliomas, where you can see that it's considered the presence of IDH wild type is considered as a molecular glioblastoma or molecular high-grade glioma, and this patient require maximal resection. If you do and they have the prognosis is better, and you prevent that this patient go to a high-grade glioma. So the FDA approved different kind of treatments, and we're gonna talk a little about all of this. FDA approved in 1977 the use of BCNU. In 1996, they used the carmustine wafer. In 2005, temozolomide, the first line of treatment for GBM. 2009, bevacizumab for recurrent GBM. 2010, using of laser interstitial thermotherapy for recurrent GBM. 2011, the use of Optune. 2014, the use of gliadel waivers for new diagnosis GBM. 2015, the use of Optune for a new diagnosis GBM. And 2021, the use of gamma-tile. So the basis of neurosurgical oncology is to do the maximal surgical resection between 95 to 98%, but try to keep that quality of life of the patient. So the keep of the quality of life in equilibrium has to exist between surgery. So the use of all these technologies allow us to do the maximal resection, but with focus to try to preserve functionality of the patient. And molecular markers are making a difference in the management for survival. And these are the minimal markers that you need to have, that is MGMT, EGFR, 1P, 19Q, P53, Ki67, and IDH. So we know that 1P, 19Q give us the presence or no presence of chemosensitivity, and also radiation sensitivity of the patients. So if you have a 1P19Q co-deletion, so you can make the decision that you can do chemotherapy first and even do surgical resection. In that way, you can control those tentacles that you cannot see in an MRI from the GBM. A paper has been described that this has some kind of benefit when you have tumors in eloquent areas. The STOP protocol has been the study treatment that have been used for a long time, when you show that chemotherapy and radiation therapy has better effect than radiation therapy alone, but it has not been enough. And some to try to progress to survival. And when this system fails, you need to use other kind of therapies. And clinical trial has been coming to be important effect in the management of glioblastomas. And the use of bevacizumab and laser intravitreal thermotherapy and other treatments has made need to increase the survival of the patient. These tumors are smart tumors. They're trying to prevent and protect the survival, and they create resistance to the temozolomide. And you have methylated and unmethylated MGMT tumors that the probability of survival change. But still, the stop protocol is right now the standard of care for treatment for these tumors after surgical resection. The RTOG 0525 tried to change the modality to treat these glioblastomas, and instead of giving the full dose of 6 weeks or 75 milligrams per meter squared, followed by 1 week of temozolomide a month, they tried to do small doses for 21 days with 1 week of no treatment. Try to see they reduce the treatment, but at the end, the result was the same. With the treatment of radiation and chemotherapy, follow these patients has been a challenge, and the use of a simple MRI was not enough to define if the tumor was growing or not. Here we have an example of an MRI that shows an increase of contrast, but when you do a blood volume, you see in the blue picture in the top, there is no increase of blood volume. And in the inferior imaging low, you see there is no increase of that blood volume. So this is considered radiation necrosis. You can see how the DW is iso-intense, and the ADC doesn't show any evidence of hyperintensity, so it's hyperintense. So this is considered radiation necrosis, and these patients do not require any other surgery. These patients just can be treated with steroids or bevacizumab. As a difference to this case, you can see how a tumor that enhanced, when you use the DW, you can see a hyperintense image. Hyperintense image means hyperdensity. And then you can see how the blood volume has an increase of blood flow to that level. So that means that this is a recurrence of tumor. This patient has a recurrence of tumor. For this reason, the patient requires surgical or treatment. So I'm going to talk a little about the different FDA treatment that we discussed. So we have the NeuroBlade or laser intravitreal thermotherapy. We have the Novo TTF or Optune. We're going to talk about parafaricicular exoscopic brain surgery, Gladella, etc. So Autolite or NeuroBlade is basically a laser that is placed directly to the tumor area using navigation or stereotaxia. And this is an example of a video when I was a fellow with Dr. Jim Barnett, and the plan for this was to try to get the biopsy. Here, we can see in a patient who has a previous craniotomy, how can we identify the area of the tumor, and then we proceed to get the navigus, and then to do the navigation. Proceed to open the dura. And then to take the biopsy. So in that time, we didn't have intraoperative MRI. So we were taking the biopsy of the patient, and with the navigus in place, we identified the tumor, and we were taking the patient to the MRI suite to then proceed to do the treatment. Here, you have the biopsy of the patient, and then you take it to the pathology, and you can see the areas of necrosis and of changes of a GBN and hemistosoma. So here you can see how we transfer the patient to the MRI suite. And then in the MRI suite, we proceed to do the treatment with laser institutional thermotherapy, or known as outlet. At this time, we proceed to introduce the guide to identify that we have the same angulation. We take the different areas of MRI. We see that the laser is going to be in place based on the angulation, and this is the laser that we place to the patient. In that time, it was known as the outer blade, and now it's narrow blade. This is a laser of argon. What it basically does is burn the tumor in the different areas, and you have a software to help you to evaluate the temperature of the brain in the area that you are treated. You can see how can you manipulate in deep and around the tumor. So basically what the laser do is give the treatment to the tumor, and everything that is inside of the white line go to apoptosis. Everything that goes outside of the yellow line, it doesn't have any effect. So you can be conformal and accurate with respect to your treatment. What is the advantage of this treatment? First of all, the advantage is you can open the blood-brain barrier, so you can have the opportunity to offer better chemotherapy treatment to the patients. And the second is you can even treat the tumor directly with conventional enhanced delivery. So basically here is an example of how you treat the patient with laser interstitial thermotherapy. So you need an MRI, you need a system that helps you to treat the patient inside of the MRI suite, and a anesthesia machine that is compatible with MRI. So in order for you to proceed to give this treatment. It's the example of what we saw in the pictures. We do different MRIs to be perpendicular to the lesion and be conformal. And these are the different lasers that are available. One is the Visualize, that is from Medtronic, and the other one is the narrow blade, that is the one that we were using, that it shows how you treat the tumor, and it's a different laser that is more conformal with respect to the lesion. Visualize more like a balloon, and this one you have the two options: the balloon or the perpendicular of the laser directly to the area, the argon laser. So like explain, everything inside of the white area go to apoptosis. Outside of the yellow area doesn't have any damage. Here's an example of a patient who was treated after receiving chemotherapy, start to present a recurrence of the tumor. We proceed to do the treatment, different MRI that we use. And this is the result of the patient at day number 1, day number 13, and day number 56. Patient has 2 years more of survival after treatment. So this is what is known as the Optune. Optune are electromagnetic field that are put in the head of the patient, and what this does is destroy this cell cycle. So prevent the cell cycle to reproduce, and because we know that in the brain the cells doesn't reproduce, but tumor cells reproduce, so we are able to prevent the cell cycle. This has it's an electrical field who go from 100 to 300 kilohertz and prevent the tissue to be developed. So this is an example of what would happen. So this is an evidence in vitro.
You see two identical
you can see,
pictures
and
of
I'm gonna put
cancer cells followed in
the
time
video so
lapse
everybody
under a
can hear.
microscope. The culture on the right is an untreated control, while TT fields are being applied continuously to the culture on the left. The first difference between the cultures appears about 2 hours after treatment start. No cell divisions are seen in the TT fields treated culture, whereas in the control culture, cells have already started to divide. It takes 12 hours for the first cell to round up for mitosis in the treated culture. In addition, cell cleavage, cytokinesis, is delayed and takes 3 hours to finish. The next difference between the cultures is that in the treated culture, cells round up for mitosis, However, they are not able to complete the normal division process at all. They remain arrested in mitosis for about 5 hours and then die through programmed cell death, apoptosis. This mitotic arrest and apoptosis is seen in dividing cells only. The dying cancer cells in the TT fields treated culture exhibit membrane blebbing, the hallmark morphologic characteristic of programmed cell death, also known as apoptosis. After almost 2 days of TT field treatment, the difference between the control and treated cultures is clear. Cancer cells fill the entire available space in the control culture, while in the TT fields treated culture, only those cells that did not attempt to divide remain alive. Cells undergoing apoptosis are also known to bind annexin to the plasma membrane. The red color seen in these pictures shows annexin bound to the membrane of cancer cells treated by TT fields. These cells subsequently undergo apoptosis.
So basically, you treat the metaphase and the telophase of the cell cycle, and the tumor cells go to apoptosis when you are treated with TTF. So these are a place that you connected to a battery. You need to have it at least 16 hours in the head to be effective. These are connected directly to the patient and are connected to the battery, and the patient needs to become used to have it on the place. You do a mapping to define where you put those electrofields, and you give to the patient batteries that are connected, and the patient become used to it. So this is a 26 years old who present with seizure. We had 3 kids that had a pregnancy 7 months ago, and the patient came with a tumor that become a GBM. This is the treatment of the patient, the pre-op ablation. And after surgical resection, we identify and we proceed to do the mapping of where you're gonna put those plates. And this is the analysis that we have before surgery. And we identify the patient and we put the plate. And this is the patient after surgery. The patient had already 3 years of survival. So you cannot give this patient who have a skull defect, shown on bullet fragment, or is sensitive to conductive, and you need to use hydrogel. So this is the only thing that is available outside that has been shown that use of Optune and temozolomide increase the survival of the patient compared to the other therapies. So for this reason, this has been part of the standard of care, and patients who use temozolomide, the use of Optune definitely is the only study has been shown in the last 5 years to increase survival. So as I mentioned before, there's different areas of treatment, and one of those is also the use of gamma knife instead of radiation to treat the patient with glioblastoma. And there are different institutions like Cleveland Clinic, Pittsburgh, UCSF, UCLA, Baptist, University of Miami, that start to also use gamma knife of area of therapy to treat these patients and use as a clinical trials for treatment. So there's new technology also help us to improve surgical resection and follow the concept of tumor stem cells that we normally know that are periventricular. Sometimes when you do resection, you are not able to get all the most metabolic part of all the tumor area. And so we proceed to do what is known as paravascular exoscopic resection of the tumor. Here is also important to remember what we discussed before, when you have two different kind of contrast, the endogenous contrast and the exogenous contrast. The exogenous contrast is the gadolinium, yeah? The endogenous contrast is the water. So we know that the diffusion image in an area of hyperintensity in diffusion in B1 will let us know if the tumor is hyperdense or is hypodense. And the ADC, if the image is hypodense, it means that it's hypercellular. So in that way, you can also identify if the patient has a tumor or has a recurrence. We also learned that the tumor displays the corticospinal tract. So if we consider the corticospinal tract as a cranial nerve, so we will be a little more careful to identify what is eloquence and what is not eloquence. Here we see an example of a tumor that is displayed in the corticospinal tract. So using this concept, we can do minimal approaches with directly to the tumor and try to get that tumor stem cells and do a maximal resection of the lesion. Here we have an example of a skull-based tumor. Instead of open the entire area, we can go with a supraorbital approach and go directly and resect the tumor. Here's an example of how we can go transfocal, and using these retractors, we can go directly to the tube area, and using an exoscope, using HDA monitor, we can see the area of the tumor that you would want to resect, and we can identify clearly what is the area to resect and what is the brain tumor. And this is an example when we remove the tumor, and you can see that there is no any brain damage established, and you were able to remove deep areas of the tumor. This concept, we also use it for hyperintensive blood clots. And here, instead of waiting the patient in the neuro ICU, we went directly and take the blood clot from the basal ganglia, and we can even see how those tracts are able to recover in an MRI control with tractography. Here's an example of a patient with a brain tumor that was displaced in the corticospinal tract. We decided to do a resection of the tumor using the exoscopic area. We identify all the area of treatment, and we proceed to do resection of the tumor using the navigation system completely. The use of artificial intelligence is also important. Most of the time, the patient gets lost in the ER or in the clinic, or when you are trying to develop a neuro-oncology area, it's important to find out how to get more brain tumors. And this is a way that we do it. We can put artificial intelligence with software in different CT scans or MRIs around your town. And when a brain tumor is identified, automatically this goes to your email, to PACS, and to the monitors and to the iPhone, and the patient can go directly to the ER, and can be people or physicians already from your team waiting for the tumor to be treated. And that way we can use artificial intelligence in different areas. So you can have a rapid identification of the right tumor, you can have a leverage to analyze the tumor, identify the brain tract, and you become efficient with rapid admission from MRIs and CT suite with the hospital admission. So other thing that has been important is the use of PHI-LA. PHI-LA not only help us to do resect and identify the borders of the tumor, it also help us to identify the most important aggressive area of the tumor, the stem cell tumors, and the most metabolic part of the area. Here we can see an example of using a spectroscopy as a definer to do a biopsy, where you can see the presence of the methionine PET scan and spectroscopy together, how inside of that area you can have a Ki-67 of 42%, and outside of that area you have a Ki-67 of 9%. So you can see how the aggressiveness is different. So you can get confused between a mixed oligoastrocytoma, between a grade 2 and a grade 3. Here's an example that if you decided to use a PET scan to identify tumor, has to be a methionine PET scan, that is the one that is used for glioblastomas. So here's an example. When you have this tumor, there are areas of hypermetabolism and areas that doesn't have hypermetabolism. You're gonna do it. If you cannot do a gross total resection, at least you need to do a resection of that hypermetabolic area. And PHI-LA is also an area to help us to identify that resection. It has been shown that resection of the hypermetabolic area make a difference. So PHI-LA is an example of how can you fluorescent or identify that areas of tumor. and identify the residual malignance. So here we have an example of the presence of white tumor versus the presence of using 5-ALA. So the 5-ALA area identified the tumor more clearly, and you can do the resection. So it's a different study that it showed the use of 5-ALA is statistically significant to identify the area of metabolism. And here's an example when you do a biopsy, an area where it's 5-ALA negative, when you can get a low-grade glioma with a Ki-67 of 5%. When you do a biopsy in a area with 5-ALA positive, when you can clearly identify an anaplastic focus with a Ki-67, and here you have a grade 3 astrocytoma. So here's another example of a patient with a tumor in the motor cortex, close to the motor cortex. When we use the 5-ALA to do resection of the tumor, and here we identify our planning before surgery, and we can see here the tumor, and we can here see exactly where the fluorescent is for do the resection. So 5-ALA is a identify a worse prognosis also in patient with IDH wild type. This is another technique that is using a augmented reality, where you can put in the microscope all the image that you have in the navigation system to identify the area of the tumor for able to do the resection. Here we have the tumor with all the functional area around it. We can also do what is known as conventional enhanced delivery. Is the novel drug delivery tool that enhances the treatment of recurrent tumors. Basically, you are able to put a catheter directly to the tumor area, and this ramify in the tumor, and you can bring direct drugs to the area of treatment, and then this way you can treat it. The company who used this is Uncle Synergy, and with the Cleveland Clinic conventional enhanced delivery system. The other thing that we use is what is known as mixed reality or virtual reality. Here's an example of a tumor that we were planning to resect, that it was getting outside of the brain, and how we were planning to leave it after surgery using this graph. So basically, we were able to remove an image from the wall or from the monitor and use it in space in the office to analyze, and immerse inside of the tumor area to try to identify how to do resection. Here's an example of a tumor with the corticospinal tracts, where we can able to see the difference of the different tracts that we need to analyze inside of the patient. This is using what is known as mixed reality, the study of the tumor in the virtual space without being immersed in a graphic area. Here's an example of the use of the MRI and the tumor in this mixed reality space. And this is known as the gamma tile. Gamma tiles are areas of radiation that you can use directly to the brain. This gamma tile has made a difference with using gamma tile bevacizumab to increase the survival with respect to the previous one already discussed, Optune resection alone, bevacizumab, increasing the survival to the patient with recurrent glioblastomas. So it takes up 5 minutes to put the gamma tiles, and these are a radiation. You need a radiation oncology to help you to pursue and do this and calculate the dose of treatment. Gamma tile therapy has increased the outcome of the patient and make a difference with respect to recurrent GBMs, and has been shown to be significantly important also in the survival of other kind of tumors, including metastases. Gamma tile plus bevacizumab increase the survival in patients with recurrent glioblastomas. If you always do what you always did, you always get what you always got. This is Albert Einstein. We always need to think outside of the box. I invite you to Miami, the different meetings and events that we have. We're going to have one in November, 2 to 5. That is the Congress of Miami of Neurosurgery. with all the Latin American neurosurgeons from US and Canada. Again, I want to say thank you for the opportunity for being here with you guys. Thank you.
Thank you so much, Jose, and thank you for your very informative presentation. And you use the very clear and concise language to summarize the treatment methods and the current status for glioma, also including many new treatment methods. As we know that human brain is also composed of molecules. So now more and more physical therapy methods such as the lasers and the electronic fields you have mentioned that have been introduced into the field of glioma treatment. My question is, how effective can this therapy be in general?
So my experience has been good. I have been doing this for almost 10 years of treatment as a neurosurgeon. As you know, patient without treatment, they have a survival rate of 3 months, and patient with regular treatment has a survival of 6 months. We are able to have even 3 to 4 years of survival in these patients. No, in 40% of the patient, I will say we can get that increase of survival. And we also do recurrent surgical treatments to the patient if it's necessary. The difference is the stratification. Not all glioblastomas are the same. So you need to identify if the patient is wild type IDH, if the patient is increase of P53, what kind of glioblastoma the patient has. My experience are the patient with EGFR amplified with a 1p90q deletion and IDH mutation only, no wild type, are the one who has the best prognosis, for resection, even for clinical trials. But you need to try all of them in the same way. When you have a recurrence tumor, now we're doing something that is no targeting therapy, meaning that when we took the tumor, we do a live biopsy and we use that tumor and see all the different chemotherapy that are available to which one of these chemotherapy the tumor is sensitive. Like when you do an antibiogram, So we do it, and if we see that the patient is not sensitive to temozolomide, so we don't treat it with temozolomide, We don't treat it with stop protocol. We treat it with what the targeting therapy tell us that the tumor is sensitive, and in that way you increase the prognosis of the patient and the survival. So that is what it makes the difference. I think mixed reality help you to understand in 3D before you go to the surgery where you are confronting. It's not ready to use it at the same time in the OR, but in your mind, you capture that image in a better way and the moment that you confront the tumor. Because sometimes it's different. I think all these techniques are important. And I think if you develop your techniques and treatment just for brain tumors, you're going to have better result than somebody who doesn't do brain tumors every day.
So is there any genetic difference in this kind of treatment, like use lasers or some like electronic fields? I mean the genetic difference, the different gene type. Mm-hmm.
So yes, like I said, the stratification is important. So the patients who are 1p90q no co-deletion, who are not chemiosensitive, they respond different. So 1p19q, just to give you a difference, these are chemiosensitive and radiosensitive. So these patients respond much better. You have low-grade gliomas who are IDH wild type. These IDH wild type are gonna be these are molecular high-grade gliomas. Yeah, these are tumors that if you don't do a gross-total resection to the tumor, and they will not respond well, and they are becoming really aggressive. So at the end of the game, this is gonna become a patient dependent more than molecular dependent. Because you can have the same molecular results, but not all the patients wanna go ahead how far they wanna go with different kind of treatment. There are patients that after one surgery, they don't wanna continue with our patient, wanna continue treatment. So stratification alone is important. I don't have any study with data to tell me how far I can go based on the stratification that I have. But I think molecular and genetics make a difference.
Okay, thank you. Thank you very much.
Excuse me, we have a question from Wai Peng of Malaysia. May I know how you decide how much of the glioma that fluorescence should be left behind in eloquent areas?
Thank you for the question. So, like I said, you always go for more than 90-95% of the resection of the tumor, but you need to keep that functionality preserved. So that means that if you do a resection of a high-grade glioma and you do it in the language area, for example, in the motor cortex area, when you start to see that the patient starts to get a deficit, that's the time to stop. You can always come back when the tumor develops plasticity. There is another subject to discuss, but it has been seen that the plasticity starts to show after 6 months. So you can go back and do resection of the tumor if you need it. Dr. Dufault has been shown in low-grade gliomas and in high-grade gliomas how he can do resection later with the intention to preserve eloquence. Yeah, so maximal resection is the goal, but functionality is important. Why? Because has been shown in different studies that if you affect the functionality of the patient, you decrease the survival. Yeah, so you need to keep that difference. So that's why if you're gonna do surgery in the left brain, in the eloquent area, you always do it awake, so you can preserve and identify the area that you're gonna treat. I don't know if that answered the question.
Thank you. Ben?
Okay, thank you, Professor Jose. And now we have to give the time to Chen Zhan.
Actually, Dr. Chen just called me. He got some problem with his computer, the Zoom connection. I mean,
Okay.
he can online, but he cannot. I mean, the use the microphone of his computer. So that's the
Yeah.
problem.
He actually
but-
had made it as far as the panel, but I can't get in. So
Yeah,
unfortunately, I think
but
we'll have to
that's okay. I
postpone it.
think it's not big deal. Yeah. So maybe we can keep the discussion, or we can just finish here. Never mind.
Yeah, Ben, what do you want to do?
Okay, so we can close this session.
Yeah,
I think.
okay, I think it's a good idea.
Okay. Thank you, Jose.
Okay,
Thank you.
Wait, Jose's in Miami. Hello out the window, Jose.
Yeah.
Yeah, Miami. He both in Miami. Right?
Okay, thank you everyone for
Okay,
coming.
thank
We'll see
you.
you in 2 weeks with Dr. William Caldwell from Utah.
Yeah, William
yes,
Caldwell.
great.
He
Yes.
is my good friend.
Oh, good.
Yeah.
You'll be glad to see
Okay,
him.
great.
Okay,
Mhm.
thanks, Jose.
Okay, bye-bye.
Thank you. Bye-bye.
Okay, we stopped the recording. Okay, got a full day today, Jose?
Sorry?
You got a full day today?
Yeah, what I mean, Sunday today, we'll see.
Oh, yeah, you take day off. Say
Yeah,
hello, Ahmad, say hi to Jose. Ahmad's from Afghanistan. Go ahead,
Hello,
Ahmad, I can't hear you.
hello, salam alaikum. Salam alaikum, hello. Professor John, colleagues, how are you? this Dr. Fizat from Afghanistan. This was very good lecture and very useful and this up to date. Thank you very much.
Nice to meet you, Dr. Ahmad. Thank you for
Yeah,
your.
Yeah, Ahmad is the head of the Afghanistan Society of Neurosurgery.
Good. Good, good.
So very good. He comes here a lot. It's always good to see him. Okay, anybody
Thank
else
you.
want to
Thank you
say
for-
hello to Jose before he goes? Anybody else? Juan Lee, you keeping busy?
Yeah, it's okay. Yeah, I'm listening.
Okay.
Okay.
Okay,
See
very
you.
good. We'll see everybody next 2 weeks.
Okay, bye.